speak to us. Thanks, Peter.
Thank you very much, Dr. Thorpe. Pleasure and honor is mine. It's a real a pleasure to be here and give you an update on reporting standards and current recommendations for stenting chronic iliofemoral venous obstruction. Certainly, this meeting by Dr. Ramaiah brings back the memory of Dr. Dietrich, and I happen to find the obituary that I wrote when I was the editor of the Journal of Vascular Surgery, and just want to recall what an extraordinary vascular surgeon, innovator, and a visionary leader that was. It's a pleasure to have this meeting remember him. These are the guidelines or recommendations that have been published in the last decades or so by the different vascular society. The most recent one was published just 2 years ago by SIR, and there is a consensus statement that Kush Desai published with a team of experts on behalf of VIVA, American Venous Forum, and the American Vein and Lymphatic Society on current management of non-thrombotic iliac vein lesion. I put up this book because I'm really pleased that it came out finally last year. This is the 5th edition of the Handbook of Venous and Lymphatic Disorders, and Dr. Murphy and Dr. Raju and Jayaraj wrote the chapter on chronic iliac vein obstruction. If you don't have your copy yet, you can get it now. The book is widely available. It tells us that the current recommendation is that in symptomatic patients with C3 and 6 disease who failed conservative therapy, we recommend venous angioplasty with stenting. And this is a strong indication not only by the authors, but by the panel of the editors. The quality of evidence is obviously still moderate, because it's still only Dr. Thorpe's randomized controlled study that was published several years ago that actually showed in an RCT that it is better than conservative management. There is a European study by a multi-center study that actually did not find a difference, and the C-TRACK study by Suresh is still waiting for completion, and probably we'll have the results back in a year or two. But again, if you want to make a strong recommendation in a guideline, you need a randomized controlled trial with a high level of evidence, and currently we don't have. The evidence that we currently have is really coming from single-arm studies, and obviously the classic study is Dr. Neglen's and Raju's paper that showed a fantastic 100% 5-year patency after non-thrombotic lesions, 86% secondary patency in post-thrombotic syndrome. These are the currently available dedicated venous stent studies, and it's wonderful to see that we have now indeed of these 3-year outcomes, and they show the benefit and the safety of these devices with low rate of complications and good patient-reported outcomes. But again, these are not controlled studies. We have new stents, and the Duo stent is certainly one of them. The other one is a Chinese stent, a mixed stent. 1-year data are out. Again, it shows the benefit in single-armed, non-controlled studies. There is a lot of information out there about a low rate of complications and about data trying to define factors that affect patency and complications of these iliac stents. And we know that in expert hands, major stent-related complications are rare, 3.3%, most frequent being crushing, fracture, wall erosion with a very low rate of death. We know that in this retrospective study, prior open surgery on the vein and prior radiotherapy predicted major stent-related complications. This is a great paper by Human Jalai, who actually also did the randomized control trial that did not show a significant difference between conservative treatment and stenting. And this study showed that the type of obstruction and the number of stents were factors that affect outcome. We also know now from studies that acute DVT and non-thrombotic lesion results are very similar. On the other hand, the post-thrombotic syndrome is the problem, and that the difference between non-thrombotic lesions and post-thrombotic lesions are significant. You see the currently published studies here. You can see that practically all of them are single-arm studies, even though they are prospective. Some of them included acute DVT, some of them did not. Some of them placed more single stents, and others used more than one stent, and primary patency again differs whether it was more post-thrombotic syndrome or more stents were used. And we also know that there is really no consensus currently on postoperative anti-thrombotic or anti-platelet treatment. So reporting standards are extremely important, and this is a Delphi consensus statement that we came up with Suresh and a group of experts from Viva. Our recommendations is that RCTs should be done. They provide the highest level of evidence that we should focus on post-thrombotic syndrome. We should use multiplane venography and IVUS to describe the anatomy. Clearly, the extent and the type of obstruction has to be described, and the quality of inflow and outflow, as you heard from presentations here. We have to state all endovascular methods in addition to stenting, because they may affect outcome. State the number of stents that you use, including the size and the type, and we should standardize antiplatelet and antithrombotic medications. And when you look at safety, the safety outcome measures include the successful deployment, freedom from early and late complications, and these studies should be at least 3-year follow-up with radiographic imaging. Finally, the efficacy outcome should consider patient-centered sequelae of venous disease and objective information on ulcers. Thank you very much.